Good morning, everyone. Thank you to NCSM for inviting me to give this talk. Thank you also to Sunway University for hosting the venue for this great congress. It's my honor to be sharing with you the research study that I have been doing together with my colleagues in Taylor's University. So the title of my talk is Cervical Cancer Screening, Integration with Artificial Intelligence. Alright, so just a very brief overview about cervical cancer, right? So we all know about the impact of cervical cancer, especially in the low and middle income countries. If you look at the rankings of different cancers among women, for the developed nations, cervical cancer's incidence in terms of the rank of top cancers among women have really dropped to quite a low position. But in the still developing countries, cervical cancer incidence is still very high due to various reasons, including low uptake rates of screening and also lack of coordination of screening programs. And also, I guess the reach of the HPV vaccine is also not so high in those countries. So yeah, I alluded to the HPV vaccination. So I alluded to this. Since the rollout of the HPV vaccines, we have seen newer versions of the vaccine that can cover more strains of the HPV or more types of HPV. But then there's a gap there because the HPV vaccine is more effective for people or for girls or even nowadays boys who are sexually naive and have never been exposed to HPV, because HPV is such a ubiquitous virus. That you can, a lot of women get it get the HPV infection at least once in their lifetime through it's sexually transmitted, yeah. So that's why there's still a role to play for screening using, for example, pap smear and other modalities of screening. Okay, next please. So these are some of the methods for screening and diagnosis. So we know that for cervical cancer, early detection is crucial, and if you can detect early, the treatment is available, and it will lead to tremendous improvement in terms of morbidity and mortality. So these are some. Previous slide. So those are some of the commonly used methods for screening and diagnosis. So we have the conventional pap smear and the liquid cytology-based pap smear, and then HPV DNA test. So in recent years, the WHO has greatly recommended HPV test. This is a PCR DNA based test. So WHO has increasingly recommended HPV tests in routine screening. However, because HPV test is very expensive, so it's not so practical to be utilized in all the countries in the world, and also in the less resource-rich countries. It's a bit of a challenge to implement HPV testing. Also, visual inspection with acetic acid and also with the Lugol's iodine assay. These are very easy, straightforward tests that can be used in the rural areas because it doesn't require any equipment. You can the clinician can just inspect the cervix by the naked eye. Next. So this slide actually just depicts the slight differences between the conventional pap smear and the thin prep liquid test. So essentially, it's the similar where the cervical sampling tool, such as a cyto brush, is inserted with the aid of a speculum, a vaginal speculum, to open up the vaginal canal, and then the clinician will insert the cyto brush and rotate and try to capture the cells, especially in the picture on the left there, at the transformation zone, or TZ zone they call it. So that is the area of the cells where the malignancy usually begins. Right? So for the conventional pap smear, the cells will be directly smeared onto a glass slide and fixed with a fixing solution, which typically contains alcohol. And for the thin prep, on the other hand, the cervical brush is then broken up and then submerged into a liquid vial and then sent to the lab, and then whereby in the lab the sample is then processed, centrifuged, and concentrated onto a small, like 20-cent coin region on the slide. And then frequently the thin prep test is done together with automation. Next slide, please. Yeah. So this is another slide that explains the differences. So the liquid-based cytology, or LBC, usually uses some sophisticated equipment. So that is why it's only available in the large district hospitals and also in the resource-rich countries or states. Next slide. So what about visual inspection with acetic acid? So this is the principle of the test. So the clinician usually cleans the cervix with a diluted acetic acid solution, wait for at least 1 minute, and then look at the changes in the morphology and in the visually, if there are white specks and areas that appear white, we call it aceto-white. So then it's a indication that the patient may have some abnormalities or even cancer. Yeah? Next. What about visual inspection with Lugos iodine? So its principle is the same, but using iodine solution, and then look at the color changes. Okay, look at the color changes, whether it remains the same, or is it the change? There's a change color to purple or to the dark blue or black, okay, or brown. Okay. Next, please. So this table shows the comparison of the different screening methods and the different parameters in terms of sensitivity, specificity, the cost, results, how long does it take to do the test and get the results, and the need for highly skilled personnel to conduct the test. So for HPV DNA test, you can see that it requires the high skills, and also in terms of the specificity, so it's different for the different tests. Next, please. And then results reliability. So for the conventional pap smear and liquid pap smear, for conventional, the reliability is moderate, because it tends to produce false negative results. For the liquid LBC, is more reliable than conventional, but still not as reliable as HPV test if it is conducted properly according to the standard SOP. But for VIA, the visual inspection methods is low reliability. But the advantage is that you do not need any equipment, so it can be done in the rural areas. And the positive results interpretation, so most of the conventional and the LBC, they follow the Bethesda classification for the cytopathology. And then for the HPV, of course, it's PCR, so or real-time PCR, so it's based on the CT value or the presence or absence of the PCR test. Next slide, please. So there are some limitations of the cytology. And so, for example, for cytology, the cytoscreeners or the cytopathologists would have to peer into the microscope and look at the different fields of view in the slide, and it's very tedious and very it causes fatigue to the eyes for the cytoscreeners and cytopathologists. Very time consuming and also error prone. It's very subjective to inter-individual interpretation. And of course, if you are more highly trained, then the accuracy will be higher. So automated screening systems have been actually rolled out and approved by FDA. So these two are the FDA approved automated imaging system. The first one is the Becton Dickinson focal point GS imaging system, and the other one is a thin prep imaging system. They were approved around the same time in around 2008-2009. And both systems were actually semi-automated slide scanning systems. And they have a simple software processor that interpreted the images of the fields of view. For the BD, if I'm not mistaken, it's around 10 FOVs. But for the thin prep, it's about 22 FOVs. Right? And then they will alert the user if there is some suspicious field of views, and they will screen out those that are negative. So then the cytoscreener can then go back and review those suspicious fields of views and give their verdict. Next, please. So because there are still some limitations to these systems, the advancement of AI-based devices is a very feasible alternative, and in fact there's a huge exponential explosion, I could say, of studies that try to develop AI systems or model to try and speed up the process and make the accuracy higher, right? So this figure shows the different AI algorithms that have been used in medical research. So you have the machine learning, and then a branch of machine learning is the deep learning. So machine learning and deep learning, the main difference is that I'm not an AI person by background actually, but I know from my colleagues is for deep learning is a branch of machine learning, and deep learning is that you do not supervise the training, so that there is more like so-called freedom, and the machine actually learns faster, and there's more possibilities of better outcome. Yeah. Next. So this is a timeline, if you like, of the development of the automated cervical screening. So it started way back so from 1920s and 1940s. 1940s is where the PET test was popularized for cervical cytology screening. And then you have the 1950 to 60 introduction of first generation screening systems in the US. And then you have the second generation, and then report of the PET news in the Wall Street Journal. And then 1995, PET-NET and AutoPET approved by FDA. Then late 1990s, the liquid-based preparation, thin prep, and later called the SurePath, approved by FDA. And then the BD focal point imaging system. And then now to 2010s to 2020s, there's more and more AI-based systems surfacing and being rolled up. Yeah, next. So this is just a brief overview of the BD focal point GS imaging system. I'm not trying to sell the system. I have no link to the company, but basically it has an automated slide processing and profiler, and then a review station. So the images and the slides are captured using a high-speed video that's automated, And then these slides will actually be ranked, okay, by the likelihood of abnormality. So they will prompt the user. So as I mentioned, correct, it's 10 fields of view. They are most likely to contain the abnormal cells. So basically, these systems are not meant to replace the job of the pathologists, but to complement their role and to make their job easier. Right? But then it's not very cost effective because there are some limitations as well. So there are some published studies that report on the performance of the systems, and the results have been conflicting. But two of the studies, such as the Maverick 8 study and the Kogan et al. Study, reported that there's significantly reduced sensitivity for the automated reading. Next, please. So as I mentioned, there's an exponential increase in the number of publications, right, of AI, especially deep learning-based automated cervical cytology. But these are research publications. So it's divided into WSI, which is whole slide imaging analysis, segmentation-based, detection-based, and classification-based algorithms. Next. So what do these AI algorithms do? How do they try to help? So basically, they try to find patterns and discriminate or discriminative features from the images. Right? In simple terms, it's like we need to give input images to the machine. So we use a training data set that the bigger the data set and the more well annotated is the training data set, then the better is the algorithm that is trained. So that is the gist of it. So the training data set has to be big enough and well annotated, and then we try to also validate using another validated data set. Right? So there will be some parameters that help us to establish and characterize how good is our system. For example, the accuracy, sensitivity, specificity, area under the receiver operating characteristic curve, or AUC, and also the F1 score. So Dr. Anand alluded to the convolutional neural network. So these CNN networks, they break down the images through several layers, if you like, layers of filters, which are capable of distinguishing some unique features, okay, or patterns, as well as the more intricate things like the edges or the textures. So these features are then extracted and used to differentiate a normal image from an abnormal or pathologic image. So we undertook a study to, first of all, try to look at the literature. So we did a systematic literature review of deep learning models in cervical cancer screening. So we asked ourselves several research questions there. For example, what data sets were used for the cervical cancer detection for AI development? Next, what are the labels used? Different data sets, they have different labels on the images. And what kind of pre-processing methods were used to pre-process and screen these images? And next, what are the proposed data modeling to detect the abnormal cells from the normal cells? So we use the PRISMA guidelines to conduct our systematic review of SLR. So we started from that is the flow chart of the PRISMA systematic review that we undertook. So from 15,000 over papers, we screened with different parameters until we reached a final number of papers of around 40 papers. Next, please. So summary of the findings from our systematic literature review were that, so for the first question, so we started and we did this SLR like in 2020, 2021. So at that time, there were limited data sets available. So those were listed there. For example, the HERLEF data set, which contains about 900 over images of normal and abnormal classes of cells. The HERLEF data set was actually constructed by researchers from the HERLEF University Hospital in Denmark. And then we had the Guanacas data set. So these the cells were categorized into 12 different categories, and I think it was from the Costa Rica group. And then you have the erudite, and then the ISB as well data set. So the ISB data set actually is like a competition or a challenge given out by this IEEE. This is the engineering and computer science professional body. They in their symposium on biomedical imaging, they provided this data set of 16 extended depth of field images and synthetic images, and invited their biomedical imaging scientists to try and come up with algorithms and see which type of algorithms are better quality. Okay. The next question we asked was, what were the kind of labels used for the pap smear cytology images? So these different data sets, they use different kind of categories and classifications for the cervical images. For example, there are some that's just based on cancer presence or absence. All right, there are some that's based on severity of the cervical cancer, but the classes of cells are quite limited. Like class 0 is normal and CIN1, and then class 2 is just pulling together CIN2, 3, and 4. CIN stands for carcinoma in situ. There are some that categorize 3 categories, for example, based on keratinizing squamous, non-keratinizing squamous, and basaloid squamous. There are also those that are 4 categories and then 7 categories as well, right? Based on the severity and the types of cells. The next question we asked was, what type of pre-processing methods that we could use on the cervical cancer detection? So, because these images that we get from the raw data, sometimes there are some artifacts, and also the imaging is not very distinct. So we need to do what we call data augmentation and data pre-processing. So sometimes we need to make adjustment on the size of the cells and flip the image horizontally or vertically. We need to sometimes the color, because the staining sometimes is very faint, so we need to enhance the color, or we need to do some adjustment on the contrast, on the brightness as well. So these are the kinds of things that we need to do for the pre-processing of the images, so that we can easily capture and distinguish the features. Alright, next. So we also asked the question of what type of machine learning algorithms were used by the different authors in those publications. So these were some of the different algorithms. So there's quite a lot of different algorithms available, right? So some are supervised, for example, the support vector machine. Some are unsupervised CNN neural networks. And also we look at the author's country of affiliation. So surprisingly, the highest number of publications came from China, followed by India, and the United States is the same as Thailand. Right, and in terms of the journal that the most of the articles published, so the IEEE Access and IEEE Journal of Biomedical Imaging and Health Informatics. These are the two journals that are the top, among the top being published. Next, please. So, in the next phase of our study, after doing the SLR review and identifying the different parameters of what others have been doing, we started to look at and try to develop our own algorithm as well. So previous studies mainly used the classical approaches, for example, image segmentation, feature extraction, and classification. So one of the things we decided to use was we look at the Herlev data set, because that's the data set that has the most classes of cells, 7 classes of cells. So this is the flow chart of our proposed framework, and it was developed under the Google co-laboratory using Python programming environment, and those were the parameters. Interesting or important to note is that the accuracy of testing for these kind of deep learning algorithms is that the lower the number of classes or categories, then the higher is the accuracy that you will be able to obtain usually. For example, if you have only 2 classes, normal and abnormal, you can get around 90%. If you have 4 classes, typically the accuracy level will decrease to 70%, and 7 classes is even lower. So that was according to Lin et al. In 2019. Next, please. So this is our framework model that we used for our digitalization of the pap smear analysis. So we have the object identification. So as I mentioned, because deep learning, you have layers of the model of how to augment and how to filter. So we come up with the input image and then resize, try to identify the nucleus away from the cytoplasm, the boundary, and then we use transfer learning process with a pre-trained model, come up with the result and the segmented image. And for the classification, then we have different classes, 7 different classes. So in that Herlev data set, they have 7 classes, so we followed the 7 classes, and we also use, so this is the training data set, and the number of images that fall within the 7 classes is not very equally distributed, I would say, but that is what is available, so we had to use that. Yeah. Oh, okay. So I will be quick. Yeah. So this is the accuracy of. We use different algorithms, so those were the accuracy numbers. Okay. Next. So the limitations of the study. So these are some of them, because there is currently a lack of a very large cervical images data set that is very well annotated and for us to use as a training data set. So that's our main limitation. We chose the Herlev data set because it's the most commonly used, and then it's based on the classification rule of the 3 tiers dysplasia system. Next. So in conclusion, so even though HPV testing has been advocated by WHO in recent years, because of the various limitations of resource and also of the fact that if you are tested HPV positive, it doesn't equate you as being cervical cancer patient. You still have to go for referral to do a further test. So cytology-based screening is still considered the gold standard for diagnosis. So that's why I think deep learning aided cytology screening still has a role to play for cervical cancer screening in terms of closing the gap between the high-income countries and the low and middle-income countries. And also, there is one limitation for the deep learning framework, which is what Dr. Anand also mentioned about data security and data privacy. But this, with blockchain and all that, and also federated learning, we may be able to overcome some of those limitations where different institutions from around the world can share their medical images and then collaborate together and contribute to a large, very huge data set, which will really increase the accuracy level of these deep learning algorithms. So I just want to acknowledge my team, Dr. Dini. She was previously from Taylor's, but she has moved on to IIU Malaysia, and Chong, who is our former Master in Computer Science student. So this work was actually funded by a prototype research grant and fundamental research grant from the Ministry of Higher Education. With that, I thank you for your kind attention.